Hello everyone, welcome. Today we are going to talk about pressure, airflow and resistance in lungs. So the relationship between pressure, airflow and resistance in lungs is quite like the relationship between the blood pressure, the blood flow and the total peripheral resistance in the cardiovascular system. So here the most important thing is airflow, which is actually driven by and directly proportional to the pressure difference between the mouth and the alveoli. So it is quite like the blood pressure difference, and the airflow is quite like the blood flow. And the airflow is inversely proportional to the airway resistance, meaning that if the airway resistance is higher, the airflow will be lower. So the relationship is Q, which is airflow, is equals to delta P, which is the pressure gradient, divided by R, which is the resistance. So the resistance of the airways can be calculated in the same way that we calculate the resistance in the blood vessels. It is described by the Poiseuille's law, and here R, or the resistance of the airway, is equals to 8 into eta L divided by pi r to the power 4. So R here is the resistance of the airway, N or eta is the viscosity of the inspired gas, L is the length of the airway, and R is the radius of the airway. And notice the powerful inverse fourth power relationship between the resistance and the size or radius of the airway. For example, if the airway radius decreases by a factor of 4, so 4, the resistance will decrease, or resistance will increase by a factor of 256, because 4 times 4 to the power 4 is equals to 256. So this will be the increase in resistance of 256 times. And as the airflow is inversely proportional or inversely related to the resistance, the airflow will actually decrease by a factor of 256 times. So if you if you decrease the radius of the airway by 4 times, the decrease in the airflow will be 256 times, and vice versa. If you increase the radius of the airway by 4 times, it will increase the airflow by 256 times. So let's talk about the factors that change the airway resistance. So the major site of the airway resistance is the medium-sized vessels, medium-sized bronchi, as opposed to the smaller airways. So the typical concept should tell you that smallest airways should offer the highest resistance, but this doesn't occur because of their parallel arrangement. And you can change the resistance mainly by decreasing or increasing the radius of the airways. So you can either contract or either relax the bronchial smooth muscle. So contraction will lead to a decreased radiation, relaxation will lead to an increase in radius and ultimately increase in airflow. So the situations where you can get a contraction of the bronchial smooth muscle are parasympathetic stimulation, irritants, and the slow reacting substance of anaphylaxis in asthma. So the contraction of the airways will lead to constriction and a reduction in radius, and ultimately there will be an increase in resistance to airflow, and the airflow will actually be decreased. And the situations where you can get an increase in radius of the airway are dilatation of the airway, which occurs due to relaxation of the smooth muscle. So sympathetic stimulation and sympathetic agonists like isoproterenol and salbutamol, albuterol dilate the airways by the action through beta-2 receptors, which actually relax the bronchial smooth muscles. So they increase the radius of the bronchus and decrease the resistance to airflow. Ultimately, as the resistance is inversely proportional to airflow, it will lead to an increase in airflow. Here we have a practice problem. A 23-year-old male complains of occasional nighttime dyspnea and wheezing. He has no history of allergies, but his older brother suffers from atopic dermatitis. Spirometry findings are normal in this patient. Which of the following is the best drug to use as a provocation test in this patient? You can pause here for a second and take the answer or pick the answer by yourself. I'm telling you the answer. The answer here is methacholine. Why is so? Look at the case. The case is about a young man who has some wheezing, so might be some obstructive disease, and his brother suffers from atopic dermatitis, which is an allergic condition and atopic condition. So this patient might suffer from atopic asthma. So to diagnose atopic asthma, there are some tests we need to do, and one of the tests is methacholine challenge test. So methacholine challenge test actually goes like this. Methacholine is a parasympathetic agonist, specifically M3 agonist, and it will actually stimulate the muscarinic receptors in the bronchial smooth muscle, causing a contraction and the reduction of the airway radius, ultimately increase in resistance, leading to a decrease in airflow. So the airflow will be reduced if someone use methacholine, and it can be used to help the diagnosis of asthma. So let's talk about now the effect of lung volume on resistance. So it's very interesting. Lung volume actually alters the airway resistance because of the radial traction that is exerted by the lung tissues, and there can be an increase lung volume and decreased lung volume. Both of them actually causes changes in resistance. Suppose we have an airway here and we have some lung tissue surrounding it, and there are some traction pull on the airway by the lung tissue. So if the lung tissues expand, the traction will be more on the outside. So the outer traction will lead to a dilatation of the airway from here to here. So there will be increase in radius, and increase in radius will cause an increase in airflow. And if someone have a low lung volume, let's talk about that situation also. Suppose you have an airway like that, and you have a lung tissue like that, which are having an exerting and pressure, which is outward traction pressure, and keeping the airway open. So if your lung volume is decreased, now what happens? Now the lung tissue will collapse. So the lung tissue is collapsing, and the radial traction pressure is actually reducing due to collapse or due to reduction in lung volume. So the airway actually gets narrower. So the radius actually decreased, and the airflow is also limited. Viscosity or density of inspired air is also an important factor which determines the airway resistance and flow. So viscosity changes the resistance of airflow. So if the viscosity is increased, like in deep sea dive, so both air density and resistance to airflow are increased. And in case of breathing a low density gas such as helium, which reduces the resistance of airflow, because helium actually has low density or low viscosity. Now let's talk about a very important concept, which is the breathing cycle. So in the breathing cycle, you have inspiration and you have expiration. So at rest, before inspiration begins, what happens to the pressure in the lungs? So you have two important pressure, which is the alveolar pressure inside the alveolus and the interpleural pressure, which is in the pleural cavity. So at rest, before inspiration begins, the alveolar pressure is actually equals to the atmospheric pressure, where actually that's why there is no exchange of air between the alveoli and atmosphere, because there is an equilibrium. And as lung pressures are expressed relative to atmospheric pressure, the alveolar pressure is said to be at zero. And interpleural pressure is actually negative. And this negative pressure is created by the opposing forces of the lungs trying to collapse, and the force against it, which is chest wall, trying to expand, and it creates a negative pressure. And the interpleural pressure can be measured by a balloon catheter in the esophagus. And during rest, the lung volume is at the functional residual capacity. So here you can see this line in the center is a resting condition. So in the resting condition, the alveolar pressure is actually zero, and the interpleural pressure is actually negative, or you can say, you can start from here. So let's start from here. So this is the rest situation where the interpleural pressure is negative and the alveolar pressure is zero. So during inspiration, what happens? During inspiration, inspiratory muscles contract and cause the volume of the thorax to increase. And as the volume of the thorax increases, it increases, or it pulls a outward traction force in the lungs, increasing the lung volume. And if the lung volumes are increased, the pressure inside the alveolus will be reduced. So there will be a negative airway pressure. And whenever you have a negative airway pressure, there will be a gradient, or there will be a difference of pressure between alveoli and the atmosphere. So as I have already mentioned, that if there is a pressure gradient, it will create a flow of air. So there will be air flow into the alveoli, and the interpleural pressure actually becomes more negative during inspiration. The cause is because lung volume increases during inspiration, the elastic recoil strength of the lungs also increases, and this is why the interpleural pressure actually becomes even more negative than it was rest. And not only this, the elastic pressure, but also the chest wall also expands outwards, and that's what actually creates more traction on the pleural cavity, creating a lower pressure. And here, during inspiration, the lung volume is increased by 1 tidal volume, and at the peak of inspiration, the lung volume totals the functional residual capacity plus 1 tidal volume. So here you can see the changes that occur during inspiration. So at inspiration, we start from an alveolar pressure of 0 and an interpleural pressure of about -3 to -4 centimeter water. So during the inspiration, what happens is increases volume of the lung actually, or increases volume of the chest cavity, creates a outward traction in the lung, decreasing the pressure in the alveolus, and this decreasing pressure in the alveolus actually causes the gradient of the pressure, and there is flow of air inside your lungs. And also this elastic property of the lung actually causes a drop in interpleural pressure from -3 to -6, and also the outward expansion of the chest wall also puts a negative pressure on the pleural cavity, reducing the pressure even more. And when you have the air enters inside the lung, it actually reduces the pressure gradient between the alveoli and the atmosphere. So the alveolar pressure gradient is actually now again 0, but the elastic recoil of the lung actually presses the alveoli more, and this pressure inside the alveoli actually causes an increase in pressure in the alveoli, and this increased pressure in alveoli actually again creates a reverse gradient, which causes the air from inside the lung to go out of the lung to the atmosphere. And here now the interpleural pressure again comes to its resting negative value. So during inspiration, the alveolar pressure becomes greater than the atmospheric pressure, and the main reason is due to elastic recoil, and the pressure gradient is reversed here. And interpleural pressure comes to or returns to its resting value, which is -3 or -4 centimeter water. But during forced expiration, the interpleural pressure can become positive, and this positive interpleural pressure actually compresses the airways and makes the expiration more difficult. And that's why in patients with chronic obstructive pulmonary disease or COPD, the airway resistance is increased here. The patient learns to expire slowly with pursed lip, and the reason behind it is to prevent the airway collapse that might occur with a forceful expiration, and the force is given due to the pressure, the increased pressure in the airways due to airway reduction in chamber or reduction in airway caliber, which occurs due to COPD. So they learn to breathe out slowly, and it helps them to prevent the collapse of the airway. And during expiration, after the end of expiration, the lung volume again returns to the functional residual capacity. So now you have a practice problem. So here the lung and chest wall compliance curves for a healthy individual are shown on the slide below. And now the question is, which of the following is the best estimate of the interpleural pressure at the point on the graph marked by the red dot? So what are the graphs here? So this is the chest compliance graph, and this is the lung compliance graph, and the blue curve is actually the chest plus lung combined compliance curve. And as you can see, this red dot is situating in a position where there is a negative pressure in the chest and a positive pressure in the lungs, and those are equal and opposite. So this must be the functional residual capacity, and at functional residual capacity the interpleural pressure is negative, which is about -3 to -5 centimeter water. So you got your answer here. We have another practice problem. Respiratory physiologists at the National Center for Neurophysiologic Research are investigating how the nervous system influences various pulmonary characteristics. Bronchi are viscerally innervated by the autonomic nervous system. Now, which of the following parameters would increase most as a direct result of vagal stimulation? So we can pause here and you can take the answer or pick the answer by yourself. Now I am solving it. So here they are asking about the result of vagal stimulation. So vagus is a parasympathetic nerve, and as you know that parasympathetic nerve have a positive effect on the contraction on the bronchial smooth muscles. So if there is contraction of the bronchial smooth muscle, the bronchial radius will actually decrease from from here to here. So as the radius is decreased, so there will be increased airflow resistance, and as the airflow resistance increases, the patient now will have to do more work to have a breathing. So the work of breathing will actually be increased. So that's all from me today. Thanks all for watching my video.